for perspective, non-mass enhancement perspective. Thank you.
My talk today is about non-mass enhancement, current perspectives and future prospects. With the emerging and increasing use of breast MRI as a screening tool for breast cancer, the importance of pattern recognition of non-mass enhancements can be understood. A breast cancer may present only as non-mass enhancement without other significant mammographic finding. The talk outlines will be about the definition of non-mass enhancement descriptors, the pathological correlates, the multi-parametric assessment of non-mass enhancing lesions, the challenges in management of non-mass enhancement, and finally, the future prospects. The definition of non-mass enhancement, according to the latest Byratt's lexicon, elaborated in 2013, non-mass enhancement is defined as a discrete enhancing area that doesn't represent a mass. Different from the mass, non-mass enhancing lesion can have stable to patchy normal glandular tissue or fat inside it. The non-mass enhancement descriptors, according to the same Byratt's lexicon, furtherly defined according to the distribution and internal enhancement pattern. According to their distribution, they are defined as focal, which is confined area of enhancement representing less than 1 breast quadrant volume, linear branching enhancement arrayed in a line or a line parallel that branches following a breast duct. Segmental is triangular or wedge-shaped enhancement with its apex pointing towards the nipple. Regional is a geographic area or large area of breast tissue, at least a quadrant. Regional, multiple regional, more than one region. And finally, diffuse enhancement, which is randomly distributed throughout the breast. According to the internal enhancement pattern, they are furtherly classified into homogeneous, which refers to uniform enhancement, heterogeneous non-uniform enhancement, clumped, which is cobblestone enhancement of varying sizes and shape, resembling a bunch of grapes or clusters of ring. Among the previously described patterns, linear, segmental, clumped, clustered ring, and heterogeneous are the terms that suggest malignancy. The pathological correlates, there are a wide variety of pathologies that can be presented as non-mass enhancement on MRI. They include malignant high-risk lesions and benign entities. The ductal carcinoma in situ, DCIS most commonly appears as non-mass enhancement lesion, mostly with a segmental or linear distribution. And according to the internal enhancement pattern, it can present as clumped, heterogeneous, or clustered ring internal enhancement. As in this case, we can see here the arrow is pointing to a linear clumped enhancement, and this is the pathological specimen confirming DCIS. Invasive ductal carcinoma also can present as non-mass enhancement. This case presented to our department in MRI unit. We can see here there is a focal area of clumped enhancement in a 37-year-old presented with a right lump on the breast. This is on biopsy was found to be invasive ductal carcinoma. Another patient presented with linear clumped enhancement along the ductal distribution and was found also on biopsy to be invasive ductal carcinoma. Another patient showing here in the left breast, we can see clumped enhancement having a segmental distribution pointing towards the nipple. This 38-year-old female presented with hard lump on left breast. We can see here in the left breast clumped enhancement occupying the whole, almost the whole breast. She was found on biopsy to be invasive lobular carcinoma. In close inspection to the right breast, we can see also multiple regional clumped enhancement on the right side. And this is the corresponding ADC map. We can show how the ADC is markedly low indicating the marked diffusion restriction corresponding to the malignant cells. The PASH is a benign entity. PASH refers to pseudoangiomatous stromal hyperplasia. There are slate-like spaces resembling blood vessels. It can occur in pre- and perimenopausal females, can present as focal or segmental clumped non-mass enhancement with persistent or plateau kinetics. We can see here, this is a focal area of clumped enhancement, a regional area of clumped enhancement, and on biopsy it was found to be a PASH. Fibrocystic or fibroadenomatous lesions can also present as non-mass enhancement on MRI. This is a 40-year-old female with prior left modified radical mastectomy for invasive ductal carcinoma. She came for follow-up. As we can see here on the T2 weighted images, there is scanty cysts and fibrocystic changes. On subtracted images, there was regional non-mass heterogeneous enhancement. We refer this patient for second look ultrasound, which was negative. So we referred her for follow-up after 6 months, which showed no change, and this was followed and found to be benign fibrocystic changes. Evocrine metaplasia also can present as non-mass enhancement. Complex sclerosing adenosis is another high-risk lesion that can present as non-mass enhancement. It is seen in premenopausal women in the 3rd through the 5th decades. Radial scar when the lesion is less than 1 centimeter, and complex sclerosing lesion is called when the size exceeds or equal to 1 centimeter. They are benign breast conditions composed of fibroelastic core with radiating ducts and lobules. On MRI, lesions may present as non-mass enhancement lesion, including linear or clumped distribution. As we can see here, this is a linear branching clumped pattern of enhancement. There was a corresponding ultrasound correlate, and on biopsy it was found to be complex sclerosing adenosis. Intraductal papilloma is another pathological condition that can yield non-mass enhancement on MRI. Ductal neoplasms it's a ductal neoplasm composed of a fibrovascular core lined with an epithelial outer layer that can be associated with hyperplasia, DCIS, or invasive malignancy, typically arising in a central duct, and on MRI they can present as linear non-mass enhancement, typically located within 3 centimeters from the nipple. And in this case, there is a linear enhancement seen within a central duct, and on biopsy it was found to be multiple papillomas. We come to the multiparametric assessment of non-mass enhancement. First, we will start with diffusion. Do diffusion and ADC play a role in characterization of non-mass enhancing lesions? The ADC value, which is used to determine diffusion restriction, is remarkable in differentiating benign and malignant lesions in mass lesions of the breast. However, previous studies report that the same can be said for non-mass enhancing lesion. Avendano et al. In 2019 stated that the accuracy of diffusion-weighted images with ADC mapping is limited in breast tumors presenting as non-mass enhancing lesions. Up to 1/3 of these non-mass enhancing lesions can be evaluated with diffusion-weighted image. We have some examples, 3 different cases. This is a case of the previously seen segmental clumped enhancement. As we can see here, this is the corresponding diffusion image. We can see high signal on diffusion. On inspecting the ADC map, the ADC map finally can differentiate between the malignant cells, the malignant tissues, which is having low ADC, and the surrounding edema that is having high signal on ADC map. This is another patient, the same patient we referred previously as fibrocystic. We can see here there is also increased signal on diffusion-weighted image, but when inspecting the ADC, we can see most of the lesion is having high signal on ADC map, and even the low signal ones is similar to that of the surrounding parenchyma. This is the case of focal enhancement. We can see there is also a correlate in the DWI of increased signal intensity, yet on the ADC we didn't found a low signal corresponding to the diffusion restriction, which was a false negative diffusion study. Do dynamic study and enhancement kinetics play a role in characterization of non-mass presenting enhancing lesions? Some studies have reported that kinetic curve assessment was effective to distinguish between benign and malignant mass lesions. Other studies have reported that kinetic curve assessment was less effective for non-mass enhancement compared with mass lesions, and morphological assessment would be more important for non-mass enhancement lesions than kinetics. DCIS lesions are representative of malignant pathologies features of non-mass enhancement, and several studies have reported that malignant kinetic curve patterns as well as benign curve patterns have been observed in DCIS. Yet, washout dynamic type could be useful in distinguishing malignant non-mass enhancing lesions. Do spectroscopy play a role in characterizing non-mass presenting enhancing lesions? Initial studies like that done by Partella et al. In 2007 found a high sensitivity approaching 100% and 85% specificity for the detection of malignancy in enhancing non-mass lesions. Yet, on later studies like that done with Tozaki and Fukuma, on 2009, MRS wasn't a powerful method for characterizing non-mass breast lesions, and he attributed this to the paucity of the DCIS cases presented by Partella et al. Studies. The challenges in management of non-mass enhancement lesions. The non-mass enhancement lesions is challenging since it's unique for the MRI lexicon and its management and follow-up lack standardization. Although radiologists make a diagnosis based on the Pirates MRI, both the inter-reader concordance rate in interpretations of non-mass enhancement lesions and the diagnostic performance to distinguish between benign and malignant lesions have been reported to be lower than those of masses, even by well-experienced breast radiologists. There is substantial overlap in the morphologic and kinetic patterns of both benign and malignant lesions. Another factor influencing image interpretation is the background enhancement. Biopsy is often necessary to distinguish between benign enhancing lesions from cancer, yet MRI-guided biopsy has many limitations, including availability, high expenses, limitations of contrast usage, and toleration concerns for claustrophobic patients. This proposal was done by Fury et al. For final classification of non-mass enhancement lesions as a primary finding in the screening breast MRI. Fury et al. Classified lesions according to the distribution and the internal enhancement pattern. If there is diffuse, multiple regional or linear enhancement and homogeneous, they call this a Pirates 3. If we have focal regional with any of homogeneous heterogeneous clumped, we categorize these lesions as Pirates 4A. And if we had a segmental enhancement and any of the internal enhancement pattern, such as clustered ring, heterogeneous clumped, or even homogeneous, we call it Pirates B. Fleury et al. Also in 2022 proposed an alternative protocol for MRI-guided biopsy for non-mass enhancement lesions found incidentally in asymptomatic patients referred for screening in MRI. First, if we have non-mass enhancing lesion on MRI, Second, we do the second look ultrasound. Of course, the ultrasound is the best friend for breast radiologists. So if we have a positive correlate in ultrasound, we will go for ultrasound guided biopsy. Then if we have negative correlate on ultrasound, we first look at the internal internal enhancement pattern. If it was classified as Pirates 3 or 4A, we can do a short time follow-up, like 6 months follow-up. And if it's Pirates 4B, and this could go directly for percutaneous ultrasound biopsy. In recent years, radiomics and machine learning have been extensively applied in the medical field. Radiomic analysis can extract many features from images and convert them into quantitative data. Subsequently, machine learning algorithms can be applied to select important features to build models. Multiple investigators have developed machine learning methods for the quantitative characterization of breast lesions on clinical image. Deep learning convolutional neural network is also emerging rapidly and be used for analysis of MRI images shown to be capable of diagnosing breast mass lesions with high accuracy. Although the diagnosis of non-mass enhancing lesions using deep learning is more challenging than for non-mass enhancing lesions than for masses, yet Zoe and Goto suggest that deep learning models they used have high diagnostic accuracy in diagnosis of non-mass enhancing lesion. Yet the clinical feasibility of AI-based machine learning and deep learning algorithms for making differential diagnosis for all types of lesions detected by breast MRI is still under research. So the take-home message, non-mass enhancement is defined as a discrete enhancing area that doesn't represent a mass. Non-mass enhancing lesions are defined with their distribution and internal enhancement pattern. The non-mass enhancing lesion is challenging since it's unique for the MRI lexicon, and its management and follow-up lack standardization. There is controversy about the role of kinetics diffusion-weighted image spectroscopy in non-mass enhancing lesions. Yet it's well agreed that washout type curves, diffusion restriction, and positive Colleen peaks are useful in distinguishing malignant non-mass enhancing lesions. Second look ultrasound can be used for assessing non-mass enhancing lesions on MRI and can guide biopsy. AI-based machine learning and deep learning algorithms may have the potential to ensure accuracy in the diagnosis of non-mass enhancing lesions on breast MRI. Finally, thank you.
Thank you, Dr. Marwa, for your interesting talk. Our next speaker is Dr. Amal